Thanks so much to Haney. Really, I concur. Wonderful, wonderful friends. I really want to congratulate Haney and all the members of the ResusX team. You continue to put on an absolutely phenomenal course, one that I feel has really become the premier resuscitation conference across all of emergency medicine, critical care, and resuscitation. So hats off to you. And I'm confident, I know we're entering into day number 2, that day 1 was filled with lots of educational pearls and fun activity. Well, Haney asked me to get things started this morning with just a few minutes on talking about any recent resuscitation or critical care articles. And I want to be important and purposeful about looking over all of the talks and trying to avoid overlap. And given the phenomenal talks that you've put together, the topics, the amazing educators, that's a hard task. But in honor of September, which happens to be in the U.S. National Sepsis Awareness Month, we're just going to focus on a few articles pertaining to sepsis with respect to resuscitation, critical care, and emergency medicine. Now, with respect to sepsis, I hope that you would agree that the tenets of sepsis resuscitation really come down to our ability to rapidly identify the patient, administer early and appropriate broad-spectrum antibiotics in a timely fashion, provide the right amount of fluids, perhaps vasopressors that for patients that need hemodynamic support, and then timely source control. You may recall last year we had an article out of JAMA that looked at source control, and much like antibiotics, timing does make a difference. Most specifically when it comes to soft tissue and skin infections and intra-abdominal sources. So the timing around source control truly makes a difference. What I'm going to focus on the next 14 minutes or so is just a few articles related to recognition, antibiotics, and then an adjunct to vasopressor support. Now, I am entirely confident, regardless of where you practice across the world, we all likely have sepsis alerts built into our electronic health record. And over the years, that may be incorporating SIRS, maybe SOFA, perhaps years ago and maybe now fallen off, even QSOFA, News, Muse, all these screening tools to help us detect or recognize earlier patients that may be at risk of sepsis. In addition, I'm confident that many of you at your institutions are probably looking at your own homegrown solution with respect to sepsis alert. And over the years, we've had literature that have looked at all of those together, but not really compared it to you and I, our physician Gestalt. Until a few months ago, this was published in the Annals of Emergency Medicine. Now, this was out of an academic emergency department in Minnesota. Adults, and they appeared critically ill upon presentation. So that is one caveat to this patient population or this paper, is that they were already parsing out someone looking sick. These weren't people that were a trauma alert, a STEMI alert, a stroke alert, presenting in cardiac arrest or active labor. These were critically ill appearing medical patients. And overall, from a physician Gestalt, they evaluated what was the physician's impression in the first 15 minutes and then at 60 minutes following patient presentation. And they did that utilizing a visual analog scale. They subsequently compared it to things that you know, SIRS, SOFA, QSOFA, along with Muse and their own proprietary machine learning algorithm for identifying sepsis. And overall, they wanted to take a look at those patients that were discharged with an ICD-10 code of sepsis. And in that documentation, was sepsis noted to be present on arrival? So who won out? They had almost 2,500 patients, about 275 with sepsis. They looked at roughly 60 attending emergency medicine faculty. And at 15 minutes, that area under the curve was highest for you and I. From a physician Gestalt standpoint, that persisted at 60 minutes, and that portended out to about a sensitivity of 85%. Now, I will say that their own proprietary machine learning algorithm wasn't too far off, but certainly it came down to, in essence, what you and I think of that patient within that first assessment. So you've heard Swami say it and many others say it. What you think of that sepsis patient or the potentially sick patient in front of you matters. And we still don't have an ideal or gold standard sepsis screening tool. Perhaps as AI gets better and we learn more, we may get to that point. But your decision-making and your suspicion of sepsis truly matters for kicking off that cascade of early antibiotics, source control, fluids, vasopressors, and any adjunctive therapy. And I would encourage you to maintain that low suspicion of sepsis. Why is that? When we look at all comers to an emergency department who are critically ill, undifferentiated, about 60% of those patients end up having sepsis. So more than half have sepsis. Now, once you've identified that patient, I feel probably the pillar that makes the most difference is the timely administration of appropriate antibiotics. And we administer broad spectrum antibiotics. And for those at risk of resistant gram-negative organisms, current guidelines recommend an anti-pseudomonal antibiotic included in that broad spectrum. What are the two most common anti-pseudomonal antibiotics we select? Cefepime and Piperacillin-Tazobactam. I'm hearing that. Now, over the years, all of you, we are very familiar with the observational studies that have looked at Piperacillin-Tazobactam, especially when given concomitantly with vancomycin and in association with acute kidney injury. We're also familiar with observational studies on the administration of Cefepime and an increased risk of neurotoxicity. But until this past year, we haven't had any head-to-head studies on the two. And so I think you know where I'm going with this, and that's the ACORN trial. This was published in JAMA a little bit less than a year ago. This was out of Vanderbilt to take a look at the efficacy or the safety of Cefepime and Piptazo when administered to patients presenting with sepsis. So these were adult patients coming into the ED or the ICU, and they had an order within that first 12 hours of presentation for either Cefepime or Cefepime or Piptazo. They were randomized either to Cefepime, now we'll talk briefly about the way it was administered, or randomized to Piperacillin-Tazobactam. They were looking at overall the highest stage of acute kidney injury or death by day 14, and as a secondary outcome, they looked for those signs of neurotoxicity, so days alive and free of delirium at day 14. You can see a little over 2,500 patients included in the ACORN trial. Importantly, over 3/4 also got vancomycin. And these were essentially our patients. 95% of the patients in this trial were recruited from the emergency department. A little over half had sepsis, and the most common sources were lung and GI. So very representative of our patient population. Ultimately, there wasn't any difference between the highest stage of acute kidney injury or death by day 14. But there was a statistically significant increase in the incidence of neurotoxicity or delirium in those that got Cefepime. Now, certainly every study that we review and you review will always have limitations, and there was a significant degree of crossover. About 18% of patients in this study got the other antibiotic. In addition to being single center and generalizability, I would also point out the administration, and we're going to touch on this in a few minutes. Cefepime was given essentially as an IV push over about 5 minutes, and we know when it's given at that rapid rate of infusion, there is an increase of neurotoxicity. In comparison, Piptazo was administered over 4 hours. We're going to pause on that and circle back with a more recent article on timing of antibiotic infusion. But nonetheless, I think the ACORN trial gives us some confidence where we may be concerned about the utilization of Piperacillin-Tazobactam with vanc. Is it actually harming the kidneys? And I think in this RCT fashion, we can feel more comfortable when we choose Piperacillin-Tazobactam. In addition, with Cefepime, I'm certainly not saying that we shouldn't be using Cefepime, but just know that with continued administration, there is a slight uptick in neurotoxicity, and especially if you're working in the ICU and continued doses thinking about that in terms of ICU or inducing delirium. Now, there is another study that it's worth pointing out, and this was just published. This actually is taking a look at mortality. Is there a mortality difference between Piptazo and Cefepime for patients with sepsis? Now, this was out of Michigan, once again, taking a look at comparing Cefepime to Piptazo. You can see here they included adult patients who came into the ED, met the CDC sepsis definition, and had received either Piptazo plus Vanc or Cefepime plus Vanc. Now, importantly, they were specifically looking at patients that did not need anaerobic antibiotic coverage. So they didn't include those necrotizing soft tissue infections, any intra-abdominal infections, any CNS infections, or any head and neck where anaerobes may be more likely to be the etiologic agent. Overall, they used an instrumental variable analysis. What is that without getting too deep in the remaining 5 minutes here? It's essentially an exogenous factor that affects treatment and can emulate a randomized clinical trial, but it isn't linked to any patient characteristic or other confounders with respect to the study. And they overall did a pretty reasonable analysis in emulating this RCT. They looked at 90-day all-cause mortality, and a few secondary outcomes were clinical cure, microbiologic cure, and then ICU mortality and length of stay. Overall, there was a difference. In fact, Piptazo was associated with a higher incidence of 90-day mortality when compared to Cefepime. In addition, those that got Piptazo also had fewer days free of mechanical ventilation, fewer days free of vasopressor support, and fewer days free of organ failure. Now, certainly this wasn't an RCT, but many are talking about this current article, and I think it's important for you to be aware of. We're going to wrap that home in just a minute on my thoughts overall on antibiotics, but I want to hit one more article that was also just published in the last 3 months, and it deals with what I just mentioned regarding Cefepime administration. As we satisfy regulatory bodies that are focused on getting antibiotics in within the hour that may not necessarily be evidence-based, there is a movement towards IV push antibiotics and perhaps do it upfront right after triage to check that box of early antibiotics. Pharmacodynamically and pharmacokinetically, there is an argument that we should be perhaps looking at prolonged or continuous infusions of antibiotics, most notably in the area of beta-lactams, Piptazo as an example. Beta-lactams are a cornerstone of our sepsis resuscitation. Their bactericidal activity is time dependent on the dosing interval. In other words, optimal dosing of a beta-lactam would say that we should have that infusion interval or the free drug concentration above the MIC for that organism anywhere from 40 to 70% of the time. And so can we really achieve that with a quick administration or the traditional 30-minute time? This brings me to this particular study. Now, there are 2 studies. The Bling-3 trial was published just ahead of this with respect to JAMA, and then this particular systematic review incorporates the Bling-3 trial data. This was a review looking at continuous versus intermittent infusions of beta-lactams, where they pulled together all RCTs looking at sepsis or septic shock and comparing prolonged versus intermittent infusions. And was there an effect overall on 90-day mortality? They had lots of subgroups that you can look through these slides at a little bit later date. But you can see they included 18 trials, 17 of which took a look at continuous infusions, 1 at a prolonged infusion greater than 4 hours, over 9,000 patients. And when we look at the 17 that incorporated 90-day or analyzed 90-day mortality, there was a benefit to utilizing continuous or prolonged infusions of the beta-lactam compared to the intermittent brief infusion. In fact, when they did their Bayesian analysis, it turned out to be a number needed to treat of just 26 to prevent 1 death with a continuous infusion. So what are my thoughts on antibiotics? In essence, I do wholeheartedly admit I tend to select Cefepime as my anti-pseudomonal antibiotic, along with vancomycin for broad spectrum. Now, in patients that need anaerobic coverage, we certainly default to Piperacillin-Tazobactam. I think ACORN gives us some reassurance that there isn't that increased incidence of AKI, but when I'm looking to administer that beta-lactam, I think it's very reasonable for you to have conversations, and this is something we are currently doing at Maryland and have switched over some of our antibiotics to actual continuous infusions to make sure that that timing is above that patient's MIC, or the organism's MIC. And lastly, in the last minute, I'm just going to touch on this one topic, and that is the addition of fludrocortisone to hydrocortisone in patients who are vasopressor refractory septic shock, whereby our guidelines recommend the administration of hydrocortisone or a corticosteroid in this setting. This was a study published a little over a year ago, and in essence, the addition of fludrocortisone orally to hydrocortisone in patients with septic shock. Now, admittedly, this was looking at a database, not necessarily an RCT. Overall, its effect on hospital death or discharge to hospice, and in over 88,000 patients, about 2,300 of which got fludrocortisone, there was a statistically significant decrease, albeit slight, but a decrease in mortality with the administration of fludrocortisone with hydrocortisone for patients with vasopressor refractory septic shock. So to that end, it may not be something that you're jumping to immediately, but it is certainly worth a conversation with your intensivist if adding fludrocortisone to hydrocortisone would be beneficial. And if you've got markedly prolonged boarding times of your critically ill patients in the setting of sepsis and you're adding hydrocortisone, give a thought to adding fludrocortisone. So with that, Haney, I think I'm going to pause because I'm up on time. Don't want to run into Dr. Krager's time. But thanks so much for getting up, getting here, and getting started this morning. I hope we've given a few pearls on just a few articles related to sepsis. My thanks, Haney, once again for the invitation.